Welcome to the Deep Dive, where we take the densest, most critical information from core sources and, well, we transform it into knowledge that really sticks.
And today we are taking on a really challenging, but I think essential task.
We are. We're doing a comprehensive structural deep dive into a cornerstone of med-surg nursing: structural, infectious, and inflammatory cardiac disorders.
That's right. And if you're a listener looking for, a shortcut to mastery, this is it. We're cutting through the sheer volume of a core clinical text. We're in chapter 24 of Brenner and Sutter's and pulling out every single crucial detail.
The clinical, the pathophysiological, the nursing management, all of it.
The whole thing. Our mission is to give you the framework to understand not just what these disorders are, but really why they matter at the bedside.
And to structure this, because it's a massive amount of material, we've broken it down into three logical parts.
Yeah.
We're going to start with the mechanical failures, the valvular disorders.
The ones that are often correctable.
Exactly. Then we'll tackle the problems of the engine itself, the cardiomyopathies, where the heart muscle is failing.
And finally, we'll explore the attacks on the heart, both external and internal, the infectious and inflammatory diseases.
Okay, before we dive into the specific pathologies, let's just frame the language a bit. There are some key terms we're going to hear over and over.
Absolutely. So when we talk about a valve failing, we're really talking about how it handles pressure, a valve that can't hold that pressure and leaks backward. That's regurgitation.
Or insufficiency. You'll hear both.
Right. And the opposite problem, where the valve narrows and blocks blood from flowing forward, that's stenosis.
And then when we have to treat these, we'll talk about valvuloplasty, which is a valve repair.
Which is almost always preferred over a full replacement.
Right. And then, of course, cardiomyopathy, which is disease of the heart muscle itself. And later on, we'll hit some key assessment findings.
Things like the ominous sound of a pericardial friction rub.
And the systemic signs of infective endocarditis. So are you ready to start with the mechanical foundations, the valves?
Let's do it. Let's start with the heart's essential gatekeepers.
So valves are often simplified, but their function is, it's incredibly precise. What is the fundamental role of these four structures in the cardiac cycle?
Well, simply put, they're there to ensure one-way flow, unidirectional flow. They open and close based on blood pressure changes during systole, which is contraction, and diastole relaxation.
And we can group them into two main types.
We can. You have the atrioventral, or AV valves. They separate the atria from the ventricles.
So that's the tricuspid on the right and the mitral valve on the left.
Exactly. And what's really unique about these AV valves is that they're physically anchored by the chordae tendineae.
Those little fibrous strands.
Right, the heartstrings. They connect to the papillary muscles, and their whole job is to prevent the valve leaflets from, collapsing backward into the atrium when the ventricle contracts under all that pressure.
Okay. And the other set, the semilunar valves.
Those are the aortic and pulmonic valves. They sit between the ventricles and the great arteries.
And they handle much higher pressures, right?
Yeah.
Especially the aortic valve. So what keeps them stable?
They don't have those chordae tendineae. Their stability comes from their structure. They're shaped like little cups or pockets. And the rigidity of the valve ring, or annulus, they basically rely on the back pressure of the blood in the aorta or pulmonary artery to snap them shut during diastole.
So when these mechanisms fail, we get those three main malfunctions we mentioned. We have regurgitation, the leaking, and stenosis, the obstruction.
Right.
But there's a third way the AV valves can fail.
Right, and that's prolapse.
Prolapse.
This is a physical deformity where the leaflet actually stretches or balloons backward into the atrium during systole. It's important because, while it's often benign, it can definitely set the stage for regurgitation down the line.
Now, it seems like a valve failure on the right side of the heart, so the tricuspid or pulmonic, would be just as bad. But the sources really emphasize that it's the mitral and aortic disorders that cause the most severe symptoms. Why is there that left-sided distinction?
It all comes down to the circulatory path. The left side of the heart manages the entire high-pressure systemic system. So if the mitral or the aortic valve fails, that failure immediately backs blood up into the lungs.
The low-pressure system.
Exactly, and that causes rapid pulmonary congestion and left-sided heart failure. The text has a great figure, 24-2, that shows this whole chain of events. Left ventricular failure increases the strain on the right ventricle, and that inevitably leads to the systemic signs of right ventricular failure, like peripheral edema.
So left-sided disease is really the direct pipeline to global heart failure.
It really is.
All right, let's focus in on the mitral valve, starting with mitral valve prolapse, or MVP. This is one you hear about a lot. It's often inherited, tied to connective tissue disorders, and surprisingly frequently causes no symptoms at all.
That's true, but the pathophysiology of the prolapse itself is pretty interesting. One or both of those leaflets balloon back into the left atrium during systole.
And why does that happen?
It's usually related to structural changes from those inherited disorders. The leaflets might be enlarged, or the annulus, the ring, is dilated. And when it does become symptomatic, it's often because it's led to chronic mitral regurgitation, which can then cause things like atrial fibrillation, an enlarged heart, and pulmonary hypertension.
And when symptoms do show up, they are remarkably nonspecific. We're talking fatigue, shortness of breath, dizziness, syncope, palpitations, anxiety. I mean, how do you even begin to distinguish that?
Often the very first clue, sometimes the only clue, is the assessment finding. It's an extra heart sound, the classic mitral click.
The click.
The systolic click. It's the sound of that redundant floppy leaflet snapping back into the left atrium under pressure. And if there's regurgitation happening, you'll also hear a systolic murmur right along with that click.
And the definitive diagnosis is an echocardiogram.
Yes, that's what's used to diagnose and then monitor it over time.
So for medical management, the focus seems to be entirely on symptom relief, especially for those palpitations and arrhythmias. The source is very clear here. You have to eliminate stimulants.
Yes, this is huge for patient education. Eliminating caffeine, alcohol, tobacco products, and also electronic nicotine delivery systems, or ANDS.
Raping.
Right. They can all trigger or worsen the arrhythmias. And another critical teaching point for nurses is that prophylactic antibiotics before procedures are not recommended anymore for the vast majority of MVP patients. That's a big change from how it used to be.
And the nursing management extends to teaching patients to be really careful about reading over-the-counter labels, right?
Absolutely. They need to avoid ingredients that can act like stimulants, things like ephedrine or epinephrine that you might find in cold medicines.
But there's a point of reassurance we can offer.
There is. The sources state that women with MVP, as long as they don't have severe complications, can generally complete a pregnancy safely and are often candidates for a vaginal delivery without any specialized cardiac monitoring.
That's great to know. Okay, let's move on to mitral regurgitation, or Inflammatory. This is when the valve fails to close completely.
Right, allowing blood to flow backward into the left atrium during systole.
What usually causes this?
It can be degenerative changes, like from MVP. It can be ischemia after a heart attack that messes with the papillary muscles, or it can be from rheumatic heart disease. But regardless of the cause, the result is the same. Chronic volume overload on the left side of the heart.
And that overload has consequences.
Big ones. The left atrium stretches, it dilates, it hypertrophies. This backlog of volume causes pulmonary congestion, which eventually strains the right ventricle and leads to systolic heart failure.
I noticed a really sharp contrast in the symptoms between chronic and acute murmurs.
Yes, and that difference in onset is critical. Chronic MR might be totally asymptomatic for years, but acute MR, say, after a massive heart attack, is a surgical emergency. It presents as sudden, severe congestive heart failure. The heart just has no time to compensate.
And the assessment finding.
It's the classic blowing systolic murmur. You'll hear it best at the apex, and it often radiates out to the left axilla. You might also feel an irregular pulse because atrial fibrillation is so common with that stretched atrium.
Since this is a volume overload problem, the treatment focuses on reducing the afterload.
Yeah.
How do the medications do that?
We use drugs like ACE inhibitors, ARBs, or direct arterial dilators like hydralazine, along with beta blockers. By reducing the resistance in the systemic circulation, we just make it easier for the left ventricle to pump blood forward into the aorta instead of backward into the left atrium.
And if that doesn't work?
If heart failure symptoms persist despite all that, then surgery, either a valvuloplasty repair or a full replacement, is required.
Okay, let's contrast that with the opposite problem, mitral stenosis, or MS, where it's a physical obstruction.
MS is almost always caused by rheumatic endocarditis. It causes the valve leaflets and the chordae to literally fuse together, and the narrowing can be dramatic. The sources mentioned the flow path can be restricted from the width of 3 fingers down to the diameter of a pencil.
Wow, that immediately explains the pathology then. Immense pressure builds up in the left atrium, blood backs up into the lungs, and that puts this incredible strain on the right ventricle, leading to right-sided heart failure.
And this is exactly why heart rate control is so essential in MS group. Even a small increase in heart rate dramatically shortens diastole, which is the heart's filling time.
Less filling time means?
Less forward flow, rapidly worsening pulmonary congestion, and a big drop in cardiac output. It's a dangerous cycle.
So the first symptom is typically dyspnea on exertion, DOE.
Yes, followed by fatigue, a dry cough, wheezing, and sometimes even hemoptysis, coughing up blood from burst capillaries in the lungs. That left atrial dilation also, again, predisposes the patient to atrial fibrillation.
From an assessment standpoint, what are we listening for?
The sound is very characteristic. You're listening for a low-pitched, rumbling diastolic murmur, and you'll hear it best at the apex.
And why does it sound like that?
It's the auditory evidence of blood trying to push through that tiny, restricted opening during the filling stents. It's rumbling because the flow is turbulent and slow.
You know, prevention here is really a public health triumph.
It really is. Effective antibiotic treatment of group A strep throat in childhood prevents rheumatic fever, and that stops this whole scarring process from ever starting.
And for management.
We treat the congestive heart failure symptoms. If there's severe atrial dilation or AFib, anticoagulation is not negotiable to prevent clots and emboli, and patients have to be told to avoid strenuous activities in pregnancy because the increased heart rate and volume can be acutely dangerous.
The definitive procedure being surgical.
A commissurotomy to split the fused leaflets or a full valve replacement.
Okay, let's move to the aortic valve now, which manages the highest pressure gradients in the entire body. We'll start with aortic regurgitation, or AR, where blood flows backward from the aorta into the left ventricle during diastole.
The pathophysiology here is fascinating because the left ventricle has to handle this massive volume overload. It's getting the normal blood return plus all the regurgitated blood from the aorta.
So how does it cope?
It responds by dilating and massively hypertrophying to try and maintain stroke volume. But here's the interesting part. To compensate for all that high pressure, the body triggers a reflex vasodilation in the peripheral arterioles.
And that reflex vasodilation has some really profound consequences for the clinical signs.
It absolutely creates the classic findings of AR. The systolic blood pressure is pushed way up by that hypertrophied LV, but the diastolic pressure just plummets because of the vasodilation and the leak back into the LV.
Which results in a dramatically widened pulse pressure.
Exactly. And that leads to the assessment finding that is such a key diagnostic insight. The water hammer, or Corrigan's pulse.
Tell us about that.
The water hammer pulse is the physical manifestation of that unstable pressure gradient. When you feel the pulse, you feel a really quick, sharp stroke. That's the high systolic pressure, followed by an immediate collapsing feeling as the pressure just rapidly drops off.
And patients can feel this.
Oh, yes. They might complain of a pounding heartbeat, especially in their neck or head.
For medical management, controlling hypertension and reducing that afterload is key. The sources are very specific about which medications to use.
They are. We use ACE inhibitors or dihydropyridine calcium channel blockers. And critically, beta blockers have to be used very cautiously, if at all.
Why is that?
It's a bit technical, but lowering the heart rate actually prolongs diastole. That extra time allows more blood to leak back into the LV, which increases the volume the LV has to manage and can actually worsen the dilation and heart failure.
Wow, okay. So sodium restriction is a given, and once the patient is symptomatic, valve replacement is the definitive treatment.
Right, and ideally before that LV failure becomes irreversible.
Okay, so our final valvular condition is the opposite. Aortic stenosis, AS, the narrowing between the left ventricle and the aorta. In adults, this is usually from degenerative calcification.
And this forces the left ventricle to generate immense pressure to overcome that obstruction.
So you get massive concentric LV hypertrophy.
Exactly. The heart compensates really well for a long time, but once that compensation fails, the symptoms are catastrophic.
DOE, dyspnea on exertion, is almost always the first symptom.
Yes, and it leads quickly to the classic signs of heart failure. Orthopnea, PND, pulmonary edema, dizziness and syncope happen because of reduced blood flow to the brain. And angina pectoris is a frequent, dangerous complaint.
Why angina?
Because that huge hypertrophied muscle demands a ton of oxygen, but the limited coronary blood flow through that stenotic valve just cannot meet the demand.
For assessment, we'd palpate a low pulse pressure, often 30 millimeter HG or less, which is the complete opposite of AR.
Correct. And we would hear a loud, harsh systolic murmur over the aortic area, and it radiates up to the carotids and down to the apex.
And you can accentuate that murmur by having the patient lean forward during exhalation.
You can. Now, while imaging confirms the diagnosis, we have to underscore a major clinical alert here.
What's that?
Graded exercise studies or stress tests are contraindicated in symptomatic AS patients. The risk of inducing a lethal arrhythmia, specifically ventricular tachycardia or fibrillation, is just too high.
So valve replacement, either surgically or via TAVR, is the only definitive treatment.
It is, and prevention really just focuses on controlling those general cardiovascular risk factors, diabetes, hypertension, hypercholesterolemia.
All right, since medical management often isn't enough for these severe mechanical problems, let's zoom in on the essential nursing duties around surgery, which is where all of this dense pathophysiology becomes really actionable.
Okay, first we have to focus the preoperative assessment. Nurses need to teach patients about the progressive nature of their disease and give them a really clear, detailed symptom checklist to report immediately.
Things like,
Any new or worsening fatigue, DOE, an increased cough, any blood-tinged sputum hemoptysis palpitations, dizziness, syncope, or angina.
and our ongoing assessment checklist requires vigilance for signs of heart failure.
Yes, so that means daily weight monitoring, meticulously checking pulse strength and rhythm for arrhythmias, and watching for any symptoms of decreased cerebral perfusion.
And you mentioned a specific medication caution for AS patients.
Yes, with nitroglycerin, the nurse has to make sure the patient understands that the venous dilation caused by nitro can cause a dangerous drop in preload and cardiac output when you have a stenotic valve.
Potentially leading to syncope.
Right, so patients should rest first and use nitro very sparingly.
Okay, let's talk about the repair options, starting with valvuloplasty, which is repair rather than replacement.
Right, this includes commissurotomy for stenosis, annuloplasty for the ring, and leaflet repair. After the procedure, a T is done immediately to confirm that the repair was effective.
For mitral stenosis, the preferred method is the percutaneous balloon valvuloplasty, which is detailed in figure 24.3.
Yes, this is done in the cath lab, often with just light sedation.
Can you walk us through the steps of that procedure? It sounds incredibly intricate.
It's highly technical. A catheter is guided from the femoral vein into the right atrium. Then a transeptal puncture is made to get into the left atrium.
Through the wall between the atria.
Exactly. The balloon catheter is then positioned across that stenotic mitral valve. And the sources describe a specialized balloon that inflates in 3 sequential sections. First, below the valve to stabilize it, then above the valve, and then the crucial middle section expands right in the valve orifice, gently splitting the fused commissures.
That does sound delicate. What are the major complications that we need to monitor for?
Creating mitral regurgitation is a common one. Other risks include emboli leading to stroke, bleeding, and potentially creating a left-to-right atrial shunt through that septal defect.
And it's important to note that while this is great for MS, aortic balloon valvuloplasty is mostly palliative.
It is. It has a high restenosis rate, about 50% within 6 months, so it's generally just used as a bridge to a TAVR.
Then we have annuloplasty for regurgitation, which repairs the outer valve ring. This requires general anesthesia and bypass.
Correct. The surgeon sutures the leaflets to a rigid or flexible annuloplasty ring to give it mechanical support,
And there's also leaflet repair.
which involves removing excess tissue or sometimes extending short leaflets with tissue patches.
Okay, moving to valve replacement. This is for when repair just isn't possible because of extensive calcification or fibrosis.
And we really have to acknowledge the shift toward minimally invasive techniques like TAVR, transcatheter aortic valve replacement, and the MitraClip for mitral regurgitation.
Post-operatively, nurses have to anticipate some pretty abrupt pressure changes.
They do. The heart has adapted to the old bad pathology, and the sudden correction puts a lot of stress on the myocardium. So patients are highly susceptible to bleeding, thromboembolism, infection, heart failure, and arrhythmias.
The choice between valve types is a huge decision, driven by durability versus the need for anticoagulation, as shown in figure 24-7. Let's start with mechanical valves.
Mechanical valves are highly durable, often lasting a lifetime. This makes them ideal for younger patients.
But the drawback is a big one.
It's non-negotiable. Lifelong anticoagulation is required because the risk of thromboemboli is massive.
Then we have tissue valves, bioprostheses, homografts, autografts.
These are less thrombogenic, which means long-term anticoagulation usually is not needed. This makes them a choice for women of childbearing age or for patients over 70.
But their drawback is durability.
Exactly. They typically only last 7 to 15 years. We should mention the autograft option, though using the patient's own pulmonic valve for the aortic position, which kind of offers the best of both worlds, great durability and no thrombogenicity.
Chart 24-1 gives us the comprehensive post-operative nursing management. Beyond the frequent vitals and cardiac assessment, discharge teaching is a mountain of information centered on 2 things: anticoagulation and infection prevention.
Yes. For mechanical valves, nurses have to teach the specific target INRs. 2.0 to 3.5 for a mitral replacement, and 1.8 to 2.2 for aortic. For tissue valves, it's usually only 3 months of anticoagulation.
And the nurse has to review all the anticoagulant precautions meticulously.
Absolutely. Looking for signs of bleeding, like tarry stools or bleeding gums, and stressing the absolute necessity of regular lab draws.
And then there's the prevention of infective endocarditis, or IE, which is paramount for any patient with prosthetic material.
This means obsessive, meticulous oral hygiene brushing, flossing, regular dental visits, and the need to report any fever, chills, or malaise right away.
The home care checklist should also reinforce activity limits, like avoiding heavy lifting and contact sports, and really hammer home medication adherence.
The patient has to understand the why behind their life-saving but pretty complicated drug regimen.
Okay, let's shift our focus completely now. We're moving from the valve mechanics to the heart muscle itself, cardiomyopathy. This is, simply put, a disease of the heart muscle that leads to mechanical and electrical dysfunction.
And the core pathophysiological concept is pretty constant across all the different types. Impaired cardiac output triggers the sympathetic nervous system and the renin-angiotensin-aldosterone system, or RAAS.
And that leads to
Increased systemic vascular resistance and significant fluid retention. This drastically increases the workload on an already failing heart, which leads to a decreased ejection fraction, or EF.
And this link to fluid overload brings up a really critical nursing consideration.
It does. Our concept mastery alert is focused on sodium. Since that RAAS activation causes fluid retention, and fluid retention is made worse by high sodium intake, stringent sodium management is the foundational pillar of nursing care for all cardiomyopathy patients.
Got it. Let's break down the types, starting with dilated cardiomyopathy, DCM, which is the most common form.
DCM is defined by significant ventricular dilation. The chambers just stretch out, but without the compensatory thickening or hypertrophy. The heart walls become thin, weak, and flabby.
Which results in poor systolic function and a really low EF.
Exactly. The muscle fibers themselves are damaged. They show necrosis and diminished contractility.
What are the main culprits for DCM?
The causes are really diverse. It can be chronic alcohol use, persistent tachycardia, uncontrolled hypertension, viral infections like the flu, chemotherapy, even late-stage pregnancy.
But there's a big genetic component too,
A
right?
huge one. Critically, we have to remember that 30 to 50% of cases are familial or genetic. A family history assessment is absolutely essential here because it can help identify asymptomatic relatives who are also at risk.
Okay, next is hypertrophic cardiomyopathy, HCM. This is the one that's infamous as the leading cause of sudden death in young adults and athletes.
It is. It's an autosomal dominant genetic disorder. In HCM, the heart muscle mass is massively increased, especially in the septum. And this leads to a disorganized cellular structure.
What do you mean by disorganized?
The muscle cells themselves are oblique and just kind of jumbled, which makes them terrible at contracting efficiently. On top of that, the coronary arterial walls thicken, which restricts blood flow and causes areas of ischemia and fibrosis.
So the functional problem is a severe impaired diastolic filling because the ventricle is so thick and the cavity is so small.
Yes, and the crucial mechanical consequence of that is left ventricular outflow tract, or LVOT, obstruction.
So the path out of the heart is blocked.
It is. The systolic anterior motion of the mitral valve actually hits the hypertrophied septum, partially blocking blood flow out to the aorta during systole. And that obstruction leads directly to syncope, dyspnea, and heart failure symptoms.
The management then reflects that mechanical dynamic. You have to maintain preload and decrease contractility.
Exactly. Patients must avoid dehydration because that decreases preload and makes the obstruction even worse. Pharmacologically, we use beta blockers and calcium channel blockers to decrease the force of contraction and minimize that LVOT obstruction.
And a key nursing education point.
These patients must avoid rapid alterations to their preload. That means skipping hot tubs or saunas is absolutely essential.
Okay, then we have restrictive cardiomyopathy, RCM. This one's the rarest type, and it's defined by rigid ventricular walls.
Right. The walls are stiff, they're rigid, and they prevent diastolic filling and stretch, even if the systolic function and chamber size are initially normal.
What causes that rigidity?
It's typically caused by infiltrative diseases like amyloidosis or storage diseases like hemochromatosis, or it could be secondary damage from radiation. diagnosis often requires an endomyocardial biopsy to identify what's infiltrating the muscle.
And the symptoms can mimic another condition we're going to discuss soon.
They can. RCM often presents very similarly to constrictive pericarditis with severe signs of poor cardiac filling, including dyspnea and cough.
And finally, arrhythmogenic right ventricular cardiomyopathy dysplasia, ARVCD, which is now often just called arrhythmogenic cardiomyopathy, or ACM.
This is an inherited disease where the myocardium, specifically in the right ventricle, gets replaced by fibrous scar tissue and fat. This leads to right ventricular dilation and significant life-threatening arrhythmias.
And there's a hallmark diagnostic finding on an ECG.
There is. It's the epsilon wave. It's a small deflection you often see at the end of the QRS complex, along with QRS widening. These patients are almost always candidates for an implantable cardioverter defibrillator, an ICD.
Since cardiomyopathy symptoms often don't appear until the disease is pretty advanced, the diagnosis usually begins with signs of heart failure. So DOE, PND, peripheral edema, chest pain.
Right, and the diagnosis relies on a careful process of elimination. You have to rule out other causes of heart failure, especially coronary artery disease.
The gold standard tool is still the echocardiogram.
It is. It lets you visualize the structure and function of the ventricles. But I'll add that cardiac MRI is really essential for identifying the specific structural hallmarks of HCM and ARVCD.
Medical management centers on heart failure control, maximizing contractility, reducing afterload, and managing fluid.
So that includes medications, a low-sodium diet, and a prescribed balance of rest and activity. Fluid restriction, usually 2 liters a day, is necessary for congestion.
But as we noted, HCM patients must avoid dehydration.
A critical distinction.
And the nursing role here expands pretty significantly into genetic counseling referral.
Oh, absolutely. Given how heritable HCM and DCM are, if a mutation is identified, both the patient and their first-degree relatives should be referred for genetic testing and counseling. This allows for early detection and intervention in people who are still asymptomatic.
When medical therapy fails, the surgical options are significant. For HCM patients with that persistent LVOT obstruction that's refractory to drugs, the myectomy or Morrow procedure is key.
This is an open heart procedure where the surgeon actually excises a portion of that thickened septal tissue to alleviate the obstruction and restore normal blood flow out of the LVOT.
It sounds high risk.
It is. Potential complications include complete heart block, which would require a pacemaker, or just failing to adequately relieve the obstruction.
Beyond myectomy, for end-stage heart disease from any of these cardiomyopathies, the ultimate option is heart transplantation.
Right, and the criteria are very strict. Severe symptoms, no other surgical options, and a prognosis of less than 1 to 2 years. Candidates are managed by UNOS, the United Network for Organ Sharing.
And the surgical technique that's preferred today is the bicaval technique.
Yes, for orthotopic transplantation. The donor heart is implanted with its atria intact. This reduces the risk of post-op conduction abnormalities compared to the older biatrial method.
Post-transplant care is just dominated by the complexity of immunosuppression.
It is. It's a difficult multi-drug regimen, corticosteroids, calcineurin inhibitors, anti-proliferative agents. The nurse is constantly managing this razor-thin line between preventing rejection and managing the massive risk of infection and cancer.
And the functional consequences of having a transplanted heart are critical teaching points. The heart is denervated, right?
Correct. No nerve connection to the patient's nervous system. It relies solely on circulating catecholamines for stimulation.
Which means its resting heart rate is higher.
Typically 90 to 110 beats per minute. And for exercise, the heart needs an extended warm-up and cool-down period because it takes time for that circulating adrenaline to take effect and then dissipate. Also, standard drugs like atropine and digoxin may have altered effects.
Most critically for patient safety, this denervation means the heart can experience a silent MI.
Yes, a silent ischemia or myocardial infarction. The patient won't feel that classic angina chest pain. Instead, the nurse has to teach them to look for signs of sudden heart failure or dyspnea as their warning sign.
And long-term complications are severe.
Very. Acute and chronic rejection, infection, hypertension, osteoporosis from the steroids, and cardiac allograft vasculopathy.
What is that?
It's an accelerated, aggressive form of atherosclerosis that quickly narrows the coronary arteries of the transplanted heart. It's a major cause of death long-term.
Chart 24-2 reminds us of the profound psychosocial impact. A lot of patients struggle with intense feelings of guilt or indebtedness toward the donor and their family.
And that can translate into non-adherence to the complex, taxing medical regimen. It's a huge psychological hurdle.
When transplantation isn't an option, or the patient is waiting, we use mechanical assist devices, or VADs.
Right, these devices support one or both ventricles, most commonly the left ventricle, so an LVAD.
And VADs have expanded beyond just being a bridge to transplant.
They have. Now, VADs are often used as destination therapy, or DT, a final treatment option for patients who aren't transplant candidates. The sources say DT now accounts for about half of all mechanical circulatory support patients.
The technology is moving towards smaller, non-pulsatile pumps.
Yes, axial flow or centrifugal pumps. And while they're often quieter and have a lower risk of certain clots, they create a new clinical reality. The patient may have no palpable pulse and their blood pressure might be unreadable because the flow is continuous, not pulsatile.
And this technology introduces a profound ethical weight, as detailed in Chart 24-3.
Yes, the issue of VAD deactivation.
When a patient on destination therapy decides their quality of life is poor and asks for the device to be turned off,
It creates this intense conflict between respecting patient autonomy, the right to refuse treatment, and the medical team's ethical reluctance. Is it withdrawal of life support, or is it euthanasia? This is a massive area of ethical and legal responsibility for the nurse to navigate.
and we also have total artificial hearts, or TAH, to replace both ventricles.
Yes, typically as a bridge to transplant, and all of these mechanical devices carry huge risks of infection, bleeding, thromboemboli, and mechanical failure that the nurse has to be constantly monitoring. Okay, let's shift now from the mechanical engine to the structures that surround and line the heart. Let's start with a condition that often sets the stage for valvular disease, rheumatic endocarditis.
This is a direct consequence of acute rheumatic fever, which follows an inadequately treated Group A strep throat, usually in school-age kids.
And the big insight here is prevention, which is highlighted in Chart 24-5. Prompt, effective antibiotic treatment of strep throat, usually penicillin or amoxicillin, prevents rheumatic fever and stops the subsequent development of rheumatic heart disease, which shows up years later as mitral stenosis or regurgitation.
A simple intervention with lifelong consequences. Next, we have infective endocarditis, or i.e., it's a microbial infection of the endothelial surface. It's rare, but the mortality rate is high.
The risk factors are crucial to know, and they're in Chart 24-6. We're talking prosthetic cardiac valves, a previous history of IE, implanted cardiac devices like pacemakers, congenital heart disease, hemodialysis, and IV drug use.
They all create a surface where microbes can latch on.
Exactly. And pathologically, the process is sequential. An injury occurs, fibrin and platelets form a clot, microbes, usually staph or strep, invade, and they cluster together to form these complex, dense vegetations.
And the immense danger here is embolization.
A huge danger. Systemic embolization is common, and up to 65% of those emboli target the central nervous system, often causing a stroke.
The primary clinical signs are fever and a new or worsening heart murmur.
And if the patient is elderly or immunosuppressed, that fever might be intermittent or even absent, which makes diagnosis really difficult.
This is where the nurse has to recognize those classic peripheral signs of embolization.
Yes, you have to have a high level of suspicion. We look for Osler nodes, which are small, painful nodules on the fingers and toes.
And Janeway lesions.
Irregular red, painless macules on the palms and soles. Also Roth spots, which are hemorrhages with pale centers in the eyes.
And splinter hemorrhages.
Reddish-brown streaks under the fingernails.
Diagnosis requires 2 positive blood cultures, aerobic and anaerobic, drawn 2 hours apart from different sites, and imaging evidence of vegetation.
And a transesophageal echo, or T, is superior for visualizing those vegetations.
Management is prolonged intensive antibiotic therapy.
Typically 2 to 6 weeks to completely eradicate the dormant bacteria that are encased in those dense vegetations. Surgery is necessary if heart failure develops, if there's recurrent embolization, or if the infection just can't be cleared medically.
So the nursing management is vigilant. Strict, timely administration of IV antibiotics, continuous monitoring for signs of systemic embolization.
Like a stroke, sudden pain, or organ damage. It's vital. And for those with prosthetic valves, you have to emphasize meticulous oral hygiene and reinforce the need to report any fever that lasts more than 7 days. It's critical.
While endocarditis attacks the inner lining, the bulk of the heart muscle itself is vulnerable to its own inflammatory process. Myocarditis.
That's a great way to put it. If endocarditis is a localized siege, myocarditis is a hostile takeover of the entire working structure.
This inflammation of the myocardium often follows a viral infection, Coxsackie virus being the most common.
Right, and it leads to dilation, mural thrombi, and muscle degeneration.
Clinical manifestations are often mild, presenting as flu-like symptoms.
Fatigue, dyspnea, chest discomfort. But it can rapidly progress to severe heart failure or sudden death. Diagnosis often requires an endomyocardial biopsy, though cardiac MRI is being used more and more.
Medical management focuses on treating the underlying cause and, crucially, mandating bed rest.
Yes, to decrease the cardiac workload and damage. And we have two major nursing alerts here. First, patients with myocarditis are highly sensitive to digitalis, so you have to monitor closely for signs of toxicity.
Like anorexia, nausea, new arrhythmias.
Exactly. And second, a really critical detail. NSAIDs should be avoided for pain or fever. Animal studies suggest they may actually increase cardiac injury and inflammation.
And because of the bed rest, anti-embolism measures are necessary.
Absolutely.
Our final inflammatory condition is pericarditis, which is inflammation of the pericardial sac surrounding the heart.
The etiologies are really diverse. They're in Chart 24/7. It can be idiopathic, viral, autoimmune disorders like lupus, post-MI, which is Dressler syndrome, or uremia.
The inflammation leads to fluid accumulation, a pericardial effusion.
And if enough fluid accumulates, it restricts the heart's ability to fill, which leads to the emergency condition of cardiac tamponade.
And chronic episodes can cause scarring and thickening.
Right, which results in constrictive pericarditis, which rigidly restricts diastolic filling.
The characteristic symptom is a very specific type of chest pain. It's often located beneath the clavicle, in the neck, or in the left trapezius region.
And critically, the pain gets worse with deep inspiration, lying down, or turning.
The key diagnostic sign, the one every nurse has to master, is the pericardial friction rub.
It's a high-pitched, creaky, scratchy sound. It's louder at the end of exhalation, and you hear it best at the left lower sternal border with the patient sitting up and leaning forward.
And to definitively rule out a pleural rub, which can sound similar,
You ask the patient to hold their breath. If the friction rub continues, it's pericardial.
management involves NSAIDs or colchicine for the inflammation and pain.
Right. Corticosteroids may be used if NSAIDs are contraindicated. And a pericardiocentesis might be performed to drain a significant effusion or relieve a cardiac tamponade.
Okay, this final section is where we synthesize all this pathophysiology and clinical data into prioritized, actionable care plans. This is where we give you the full picture of professional responsibility. Let's start with the nursing process applied to the patient with cardiomyopathy.
The initial assessment has to be extremely detailed. You need an extensive history covering all the etiologic factors, recent illnesses, alcohol use, chemotherapy, and a crucial family history check for sudden death.
And we use tools like the NYHA functional classification to grade symptom severity.
We do, and the psychosocial history is essential. You have to screen for depression, which is highly prevalent in heart failure patients, and assess how the disease is impacting their life roles.
For the physical assessment, it's meticulous detail. Vitals, calculating pulse pressure, palpating for a displaced point of maximal impulse, auscultating for S3 or S4 heart sounds and crackles, checking for JVD and peripheral edema.
The core nursing diagnoses really center around impaired cardiac output and activity intolerance. And the big complications are heart failure exacerbation, lethal arrhythmias, and embolism.
So interventions to improve cardiac output during a symptomatic episode often involve mandated rest.
Yes, and we teach patients that sitting up with their legs down is often the position of comfort,
Why is that?
because it pools venous blood in the periphery, which reduces preload and eases that pulmonary congestion.
Medication adherence is a major teaching point.
A huge one. It often requires using pill boxes or associating taking medications with meals. And of course, you're vigilantly monitoring treatment effectiveness through daily weight checks and assessing for changes in shortness of breath with activity.
For activity tolerance, we teach energy conservation techniques.
Alternating rest and activity cycles. The classic instruction is, sit down while you're shaving or chopping vegetables.
And crucially, for HCM, ARVCD, and RCM patients, the warning is absolute.
Strenuous activities and competitive sports are strictly forbidden. The risk of sudden death is just too high.
Psychosocial support is equally critical.
You have to acknowledge the grief over lost abilities, but also help patients identify the areas they do control, like their diet, their medication adherence, and proactive symptom management.
The patient education, summarized in Chart 24-4, is paramount for success at home. They have to understand the rigid sodium restriction.
Less than or equal to 2 grams a day, avoiding all those canned and processed foods.
They need to know that a weight gain of 2 to 3 pounds in a day or 5 pounds in a week requires an immediate call.
And given the high arrhythmia risk in cardiomyopathy, CPR and AED training for family members is a crucial nursing intervention.
Okay, finally, let's apply the nursing process to the patient with pericarditis.
Assessment here begins and ends with pain evaluation. You have to differentiate pericardial pain from an MI. Remember, pericardial pain changes with position and respiration.
And you must perform that auscultation maneuver to confirm the pericardial friction rub continues when the patient holds their breath.
And also monitor for an abrupt onset of fever.
Interventions focus squarely on pain relief.
Right. Chair rest, sitting up, leaning forward. That's the position of maximal comfort because it pulls the heart away from the parietal pericardium. You monitor their response to the NSAIDs and colchicine and watch for GI side effects. And activity resumption must be slow and gradual, only after the pain, fever, and rub are completely gone.
But the highest priority for complication monitoring is for cardiac tamponade.
This is a scenario that requires absolute vigilance. The nurse must recognize the classic signs of fluid buildup restricting the heart.
Which are?
Restlessness, a progressive drop in systolic BP, and tachycardia. You are looking for the clinical triad known as Beck triad.
Hypotension, muffled heart sounds, and elevated jugular venous pressure.
Exactly, combined with pulsus paradoxus, a drop of 10 millimeter Hg or more in systolic BP during inspiration. Recognizing those 4 clinical signs means you notify the provider immediately and prepare for an emergency pericardiocentesis.
That summary really connects the docs directly to the bedside. So
Yeah.
what does this all mean when we bring all these structural and inflammatory issues together?
Well, I think the key takeaway is the profound interconnectedness of all of this cardiac pathology. It often starts years earlier. A seemingly simple case of strep throat in childhood, if it's left untreated, can start a chain reaction that leads to rheumatic fever and eventually mitral stenosis in adulthood.
And similarly, a life-saving mechanical valve replacement, while it corrects one huge structural issue, it introduces a lifelong, non-negotiable risk for infective endocarditis.
Exactly. It places this ongoing responsibility on the patient for meticulous hygiene and symptom monitoring.
And here is the most profound consideration, I think, that bridges technology and human dignity, building on those life-saving therapies we discussed. It's the ethical complexity introduced by advanced technologies like the LVAD.
Right.
We explored the scenario where a competent patient on destination therapy determines their quality of life is poor and asks for the device to be turned off. That decision, the voluntary cessation of life-sustaining technological support, it rests entirely on a conversation between the patient and their healthcare team.
And that represents a level of nursing responsibility that extends so far beyond just monitoring clinical metrics. It dives into the deepest ethical waters. It forces us to reconcile autonomy with the medical imperative to preserve life.
Something to ponder as you reflect on this critical chapter.
An incredibly important consideration for every clinician entering the field.
Thank you for joining us for this intensive deep dive. We hope you feel you have mastered the essential structural, infectious, and inflammatory cardiac disorders.
Until next time.